Padma Chutoo, and today I'm going to present on our project called The Use of Big Health and Actuarial Data for Understanding Longevity and Morbidity Risk. This is a project funded by the ARC of the IFOA. My target condition is stroke, and my project title is Stroke Mortality and Morbidity in the UK. So today I'm going to talk what is stroke, some stroke statistics, about the project methodology, few exploratory analysis, and the modeling results. First of all, what is stroke? A stroke occurs when the blood vessel in the brain ruptures or bleeds, or when there is a blockage in the supply of blood towards the brain. Now, this rupture or this blockage prevents blood and oxygen from reaching the brain tissue, and they slowly start to die. We have two major types of stroke, the ischemic stroke and the hemorrhagic stroke. The ischemic stroke is caused by blood clot and is the most common one, occurring in 85% of the cases. The hemorrhagic one is caused due to the rupture of blood vessels and bleeding in the brain. We have another type of stroke which is called the transient ischemic attacks, or TIAs, or mostly known as mini strokes. Though they are not termed as a serious stroke, however, we need to take them quite seriously because they serve as warning signs for future strokes. Stroke is quite a dangerous medical condition. It is the fourth cause of death in the UK. We have roughly around 2% of the population who are stroke survivors, which makes up around 1.2 million people. It is also the major cause of disability in the UK. Almost 2/3 of UK stroke survivors will leave hospital with a disability. Because of this, the NHS and the social care costs associated with stroke are estimated to be 1.7 billion a year in England. It also increases the DALYs, the disability adjusted years. DALYs are basically years lost due to physical impairment or due to premature death. It was estimated to be 38 million in 1990 and is expected to rise to 61 million DALYs in 2020. Now, a brief description about stroke study. So this study has been designed to model the impact of ischemic stroke and transient ischemic attack on longevity and morbidity risk in the UK residents. The study period spans from 1986 to 2017. So we have chosen cases such that they had ischemic or the transient ischemic attack for the first time after 1986. We excluded patients who had major cancers, dementia, CKD, stage 4 and 5, and hemorrhagic stroke because these are life-limiting conditions. The primary outcome is all-cause mortality, and the secondary outcome are further stroke, dementia, heart failure, myocardial infarction, and peripheral arterial disease. We're going to use a Cox model, which has been explained earlier by Elena. The variables that we're going to use in the models are drugs such as antihypertensive, anticoagulant, lipid regulating, and anti-diabetic drugs, and some medical conditions such as asthma, atrial fibrillation, chronic kidney disease, coronary heart disease, peripheral arterial disease, hypothyroidism, chronic obstructive pulmonary disease, diabetes, hypercholesterolemia, hypertension, and depression. And also demographic and lifestyle conditions such as blood pressure, cholesterol, BMI, gender, DOB, age, smoking and alcohol, and IMT decide. We extracted around roughly 34,000 cases of ischemic stroke and 95,000 control. We extracted another 34,000 cases and associated control of around 96,000. Because medical records have missing data, we could only get full records for 12,000 cases matched with 20,000 controls for ischemic stroke and 14,000 TIA patient full records with associated 24,000 controls. Now we're going to explain some exploratory descriptive diagrams. The following is the age distribution at entry for ischemic stroke full cases. So the first one on the left relates to the males and the second one for the females. So for the male, we can observe that stroke can occur as early as 39 years old and can occur also at later ages at 80 plus. But the most common ages to experience ischemic stroke would be 66 to 70 and 71 to 75, whereas females tend to experience ischemic stroke at later ages. We also did some exploratory analysis for the TIA, and we can observe the same pattern as observed earlier for the ischemic stroke. The next diagram are Kaplan Meier plots. Kaplan Meier plots show the survival probability with time. The lower it is, the poorer the survival outcome. So in the first diagram in the left is a Kaplan Meier plot by gender and case control status. Case control status means case whether they had the stroke, control, and if they didn't have the stroke. So in this first diagram, the dashed lines represent cases and the solid line represent controls. If we compare the dashed line with the solid line, we observe that cases had poorer survival prospect compared to the control. Now, based on the color, pink has been used to represent female and blue has been used to represent males. So as we can say, males have poorer survival prospect compared to the female. In the diagram on the right is the Kaplan Meier plot by age group and case control status. So we have split age into three groups: the less than 60 years, the 60 to 79, and the 80 plus. So as we can observe again, the group of dashed curves represent cases and the solid one represent controls. And again, the cases have poorer survival prospect compared to the control. And as we can see, if we are older, we have poorer survival prospect. We further observe that the gap between case control for different age group tends to get smaller as age increases. We did the same for the TIA and we got same pattern as the ischemic stroke. That is, male had poorer survival prospect compared to the female, and the older age group had poorer survival prospect compared to younger groups. Now, the model used is Cox proportional, and Cox proportional model has been developed by Cox in 1972, which is a regression model on the log hazard scale. So it's commonly used in medical research for investigating the association of survival time of patients and one or more predictive variable. So the Cox proportional hazard regression will be basically modeling the hazard. So what is hazard? It's mostly known as instantaneous force of mortality, and it can be simply interpreted as the risk of dying at time t. So we can explain the hazard function in two parts. The first part is the baseline hazard function, and the second part is the vectors of unknown parameters beta and predictors u. One of the main assumptions of the Cox proportional hazard model is that the effect of the predictor variable on survival are constant over time. Hence, the hazards are proportional. The hazard ratio for two groups with different predictor variable is constant, and the hazard curve should be parallel on the log scale. So, we use a Cox proportional hazard regression model. However, we found violation of the proportional hazard assumption. So we then proceeded to apply a parametric Cox model. A parametric Cox model is similar to a Cox regression model, but in addition, it assumes a particular distribution for the baseline hazard function and includes an additional model for its shape parameter. Consider two possible distributions. We found Gompertz and Weibull quite good fit. But Weibull could explain the data pretty well for the first 20 years, compared to Gompertz, which had some few departures. Also, judging from the AIC criterion is called the Akaike information criterion, and it's defined as a relative measure of statistical model. So the lower the AIC, the better the model is. So we can observe the AIC for the Weibull was smaller than that of the Gompertz. So based on that, Weibull distribution was judged to be the best one to model the baseline hazard function. Now, the baseline hazard function was modeled through a Weibull with parameters k for shape and scale as lambda. And the k was also allowed to be a function of u, that is, it was an additional regression model to allow varying shape depending on covariate. So different variables were adjusted in the model, such as age categories split into 4, birth cohort split into 5 categories, gender, BMI, Townsend, smoking status, alcohol consumption, some medication, anticoagulant, antidiabetic, antihypertensive, and statin, some medical condition as explained earlier, and interactions such as age category with stroke, age category with statins, stroke and smoking, and stroke with gender. So let's talk about the results now. So regardless of stroke, the male gender was associated with a higher risk of all-cause mortality, with a hazard ratio of 1.54. Being underweight conferred more risk of death, with a hazard ratio of 2.1, overweight with a hazard ratio of 0.8, and obese with a hazard ratio of 1.1, compared to the BMI normal category. So this result is in accordance with the often described bathtub pattern of BMI's association with all-cause mortality, based on Fletcher's 2014. Patients who were diagnosed with atrial fibrillation, COPD, or diabetes type 2 had raised hazards of 1.53, 1.73, and 1.53 compared to patients who were never diagnosed with these comorbidities. The diagram on the right represents the hazard curves of the different birth cohorts with time. So we can observe that people who were born earlier had high hazards. For example, this solid curve represent people who were born in the 1921 and 1930, and this dashed one represent people who were born in 1951 to 1960. So this is clearly showing improvement in life expectancy due to medical advancement. Now, what is the impact of stroke on all-cause mortality? The following two diagrams represent the result based on males. The diagram in the left panel represents male subjects who were less than 77 years old, and the diagram on the right represents male subjects who were aged 77 and above. The blue dashed line represents patients who didn't have stroke and who were non-smokers. The gray dashed line represents people who didn't have stroke but who smoked, and the solid blue represents people who had stroke and were smokers at the same time. So as we can see, the shift from the blue dashed line to the gray dashed one is very small. That is, the effect of smoking is smaller compared to the effect of stroke. So that is the change from the blue dashed line to the solid line. The effect of stroke is quite big. So at 5 years, the difference between the risk of someone who didn't have stroke versus someone who had stroke at 5 years was around 1%, at 10 years around 4%, at 15 years 6%, and at 20 years around 8%. The same pattern is observed for older patients. So at 5 years, the difference between a person who didn't have stroke and a person who had stroke was around 3%, at 10 years at 4%, and at 15 years another 4%. So the increase of hazard due to stroke. The same pattern is observed for female. The hazard increases with time, and the hazard due to stroke is quite big compared to the hazard of smoking. So this is the result so far. Our next stage of research would be doing the survival model of the TIA, then doing multiple imputation on both model and modeling the imputed data, and then finally translating this model into actuarial analysis. So as we can see, stroke is quite a dangerous medical condition. It is not only associated with high risk of disability, but also high risk of mortality. This research is quite important for different parties. For example, the individual for planning of resources such as retirement, for the government for the planning of resources or social care costs, for example, and especially for actuaries for pricing of annuities and the planning of and design of products such as life insurance, health insurance products. Finally, this research gives us hope that it can save our loved ones and ourselves from disability and premature death. That is all for me for today. I thank you very much for your kind attention. We promise to bring you more results in the near future. Thank you.